All right. Good evening, everyone, and welcome to this month's installment of the webinar series here at New York Gastroenterology Associates. I'm Suzie Finkel, and I'm one of the dietitians here at NYGA, and I'm so excited to introduce tonight's talk to you. This month is actually National Nutrition Month, and if you didn't know, we've expanded the nutrition services at New York Gastro, and now we have the largest nutrition team of any independent gastroenterology group in the city. So it's very fitting that we also have part of the GI nutrition team here tonight to present on a really important topic in healthcare and in gastroenterology, which is the health at every size movement and weight inclusivity. And our presenters are going to tell us about what that is. So tonight you're going to get two for the price of one because we have two of my amazing colleagues here, Shira Hirshberg and Faith Aronowitz. Shira is a registered dietitian who works both on the NYGA nutrition team and runs a Rhode Island-based private practice. She has an extensive background in nutrition research, community nutrition, clinical nutrition, and higher education. She earned her master's in nutrition from the University of Rhode Island and completed her clinical training at Brigham and Women's Hospital in Boston, a Harvard Medical School teaching hospital. She also taught online courses at University of Rhode Island and has planned and presented numerous workshops specifically focused on medical weight stigma, both for medical residents and working healthcare providers, and has tremendous insight to share with us all tonight. Faith is also a registered dietitian here in New York at New York Gastro and has a special interest in the convergence of GI disorders and eating disorders. She earned her master's in nutrition from Columbia University and completed her clinical training there as well. She's worked both in inpatient and outpatient behavioral health settings, and she employs a weight-inclusive approach in her nutrition practice and is going to talk to us about what that means tonight. So just a few housekeeping pieces. This webinar is going to be recorded. So if you can't stay for the whole thing, or you want to dip out early, or you couldn't even make it this evening, you'll be watching this later on repeat, and you'll also be able to share it with others. We're going to have a Q&A portion at the end too, a time where you can ask some questions that you can actually put in the Q&A box you'll see at the bottom of the screen. That's where you can put any questions for the presenters that I will be looking through as they're talking. Please don't use the chat box. That will be just left alone there. If you have anything that you want to ask, put it in the Q&A. And just a reminder, we can't answer any personal health questions, anything that pertains to you very specifically, but we're happy to answer more general questions that you have. So without further ado, we can begin. Shira and Faith.
Okay, thank you, Suzie. So Shira and I are very excited to be here tonight presenting this talk entitled Health at Every Size and GI Care, a weight-inclusive approach to gastroenterology and nutrition. And it's a topic, as you can probably see from our bios, that we're both extremely passionate about. So let's go ahead and dive in. Okay, so we'll start with the overview for tonight. We'll start off talking about some misconceptions involving weight and health, weight stigma in general, and what weight stigma might look like in healthcare. And then we'll discuss the weight inclusive approach, including the health at every size or HAES movement. And we'll end with some examples of how a weight inclusive dietitian might practice and provide some suggestions as to how to deal with weight stigma in healthcare. The first misconception we want to highlight tonight is that your body size determines your health. The chart here shows how the relationship between the number of healthy lifestyle habits you engage in and your risk of all-cause mortality at different body sizes. On the right-hand side of the slide, you'll notice the 4 different healthy lifestyle habits represented in this chart, which are 1, not currently smoking, 2, eating 5 servings of fruits and vegetables per day, 3, doing something physically active more than 12 times per month, such as walking, gardening, or yard work. And 4, drinking moderately or less than moderately, meaning 1 or fewer drinks per day for women and 2 or fewer drinks per day for men. So you can see that the lightest bar in the chart represents the smallest bodies as measured by BMI, body mass index, and the darkest bar represents the largest bodies. We'll actually get back to BMI in a few slides, so hold that thought for now. But this chart tells us that if you have a BMI over 30 and don't engage in any healthy lifestyle habits, then yes, you're at higher risk of death compared to people in smaller bodies. But if you engage in even one of these healthy lifestyle habits, the risk drops dramatically. If you look across the groupings from 0 healthy lifestyle habits to 4 healthy lifestyle habits, you'll notice the risk continues to drop as each additional healthy lifestyle habit is added. So if we look at the 4 healthy habits grouping over there on the right, you can see that the 3 bars are just about the same height, indicating that people who engage in these 4 different healthy lifestyle habits, independent of their body size, have just about the same risk of all-cause mortality. And so another common misconception is that many people believe that you can tell whether someone is healthy by simply looking at them. As we demonstrated in the last slide, someone's health status is determined much more by their behaviors than by their size. We know that there are people of all body sizes who are very healthy, and likewise, people of all body sizes who are very unhealthy. Sometimes their choices impact this, but often they don't. I'm sure you might all be able to think of somebody who, might make many healthy lifestyle choices, but who might, unfortunately have a major health condition like cancer or an autoimmune disease. The misconception can also have a significant negative impact on diagnosing eating disorders in people in larger bodies. Eating disorders are often missed by healthcare providers who don't realize that the reason for drastic weight loss may be due to eating disorder behaviors such as restriction. If you're someone in a larger body, you know that this misconception comes up with friends, family, and in the workplace through discriminatory practices like higher healthcare costs for people based on a variety of measurements, one of which is body mass index. You also know this comes up in the offices of healthcare providers who may do extra tests on you that they wouldn't necessarily do on someone of the same age and sex who is in a smaller body. This may also negatively affect people in smaller bodies as they may not get testing that would identify health issues they may have had earlier on. For example, hemoglobin A1C to check average blood sugar or an EKG to check for any heart issues. Another common misconception is that you can tell what someone eats by looking at them. Many people assume that someone in a smaller body has a healthy diet and that someone in a larger body has an unhealthy diet. When working as a dietitian and asking people about what they eat all day, every day, you learn very quickly that this is not the case at all, and that there's a large variety of diets in people of all sizes. Truly, the only way to tell what someone eats is to ask them. The last common misconception we'll discuss tonight is that one's behaviors are the only thing that determine health status. The health-focused culture that we live in now sometimes make it seem like if you do, quote unquote, all the right things, you'll have total control over your health. There are, of course, many things about our health that are completely outside of our control. This image here on the left-hand side represents the social determinants of health, which are the conditions and the environments where people are born, live, learn, work, play, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So these include things like physical environment, such as access to safe homes, water, clean air, safe schools and workplaces, and parks and playgrounds. It also includes education. Research has shown that lower education levels are associated with poorer health status. Socioeconomic status is another social determinant of health. Higher income and social status have been associated with better health status. And to give a little bit more detail here, One nationally representative study examined socioeconomic status and mortality and found that those in the most disadvantaged quarter of the study population had almost triple the risk of death compared to those with the highest socioeconomic status. It also includes social support, which includes close bonds with family, friends, and communities, as well as religious and cultural customs and traditions, and as well as access to quality healthcare services such as physical therapy, mental health services, and dentistry. So while personal behaviors and coping skills such as balanced eating, physical activity, stress management, and other behaviors such as alcohol use or tobacco use certainly impact our health status, these social determinants have a major impact on people's health, well-being, and quality of life. And of course, these determinants are not distinct entities in themselves, but rather they relate to each other in many ways. For example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. And that raises their risk of health conditions like heart disease and diabetes, and even lowers life expectancy relative to people who do have access to healthy foods. So the social determinants of health often drive an individual's ability to engage in health behaviors. Just promoting healthy choices won't eliminate these and other health disparities. So instead, public health organizations and their partners in sectors like education, transportation, and housing need to take action to improve the conditions in people's environments. But that is another topic for another evening. So the result of all of these misconceptions is that people are discriminated against in a variety of ways because of their body size. This is called weight stigma. It's also known as weight-based discrimination, but we will use the term weight stigma for tonight. Weight stigma has been shown to have negative consequences for both physiological and psychological health. In this review, Wu and others examined the effects of weight stigma on adults in larger bodies and found that those who experienced more weight stigma also experienced worse physiological health. Experiencing more weight stigma was shown to be related to increased difficulty taking medications as prescribed, higher blood sugar, increased risk for type 2 diabetes, elevated C-reactive protein levels, which is a marker of inflammation, and higher cortisol levels, which is a stress hormone. And as you all know, especially if you have experienced it, discrimination is stressful, and many people might turn to food and eating as coping mechanisms to manage stress. So it follows that people who experienced more weight stigma were also more likely to have eating disturbances, such as overeating, more symptoms of depression, anxiety, body dissatisfaction, and lower self-esteem. They were also more likely to experience more social isolation and social phobia, as well as panic, post-traumatic stress syndrome, and antisocial behavior. So weight stigma has been documented in healthcare professionals, including physicians, nurses, psychologists, and dietitians, and therefore many patients have stigmatizing experiences in these settings. However, it is important to point out that healthcare experience can increase or decrease weight stigma, depending upon a variety of factors. Some practices that can increase weight stigma are: one, getting weight advice when unrelated to the reason for the visit. For example, if somebody comes in with a sore throat. I'll dig a bit more into this example on the next slide. So while some medical guidelines recommend that those with a BMI above 30 are automatically provided with weight loss and nutritional advice, regardless of the reason for their visit, this is a significant stressor for patients and leads them to avoid medical care entirely, which may also lead to worsened health outcomes. Being weighed at every medical visit also increases weight stigma. For many people, getting weighed at the beginning of every medical visit is extremely stressful and makes them worried that they will again have to have a conversation with their healthcare provider about their weight. It's also true that sometimes people in different size bodies receive different recommendations based on their body size. For example, someone in a smaller body with prediabetes is told to eat a low glycemic diet or referred to a dietitian, but someone in a larger body with prediabetes is told to lose weight and not given any specific dietary recommendations at all, even though those same recommendations would help them as well. And some healthcare providers may not have the appropriate medical equipment to accurately assess those folks in larger bodies. For example, blood pressure is a very important measure of health, but people in larger bodies may receive falsely high readings due to a blood pressure cuff that doesn't fit them. And finally, patients in larger bodies may experience weight stigma due to stigmatizing language used by healthcare providers, which may include complimenting patients on weight loss. People can lose weight for all sorts of reasons, including chronic physical illness, eating disorders, depression as a side effect of grief. So the assumption that weight loss is always intentional and a desirable outcome can often be upheld by weight stigma and healthcare. However, someone may simply be really struggling mentally, physically, or emotionally. So I don't know if anyone is familiar with this memoir, Hunger, by Roxane Gay, but if you're not, Roxane Gay is an American author and academic who wrote an intimate memoir in 2017 called Hunger, in which she recalls a brutal sexual assault in childhood, after which time she began to gain significant amounts of weight. She writes vividly about her experiences as a person living in a larger body, specifically related to how others treat her in a professional, medical, and even mundane community encounters. In one anecdote, she recalls going to a doctor for a sore throat, which turned out to be strep. And the doctor talked to her about weight loss, which clearly does not address the reason that she came in. And then the doctor coded obesity as her primary diagnosis for that visit. This is an example of weight stigma, a seemingly small gesture or interaction by a healthcare professional that prevents a person in a larger body from feeling respected in a healthcare setting, and often dissuades them from seeking healthcare until they are extremely sick and have no other choice. And I'd like to read this quotation you see on the slide from an interview that Gay gave about her memoir to a Canadian publication, The National Post. I definitely hope that people gain a different empathy for different bodies. I would love for doctors to read it and remember their oath and treat fat bodies better. As I say in the book, you can talk to me about my weight as a medical professional, but when I come into the office because of a sore throat, you can't write on my chart obese. That's not why I'm there. I'm really there for some penicillin. Give me the penicillin. I mentioned earlier in the talk that we would come back to BMI, so here we are. This topic could fill an entire presentation in itself, so here we will highlight some key points. First, it's important to understand that BMI, also known as body mass index, is not a diagnosis. It's simply a way to describe your body size. The equation for BMI is your weight in kilograms divided by your height in meters squared. And it's used clinically because it's cheap and easy. It can be done in a doctor's office very quickly. However, the BMI equation is overly simplified and does not account for differences in age, body frame, or body composition. And there are many examples that show us how poorly it often works. For example, weightlifters are often classified as quote unquote obese because they are heavy due to high muscle mass. This classification certainly doesn't give their healthcare providers any useful information. It works especially poorly on both the very short and very tall ends of the spectrum. So for example, a man who is 6'4" and is 153 pounds is within a quote unquote healthy BMI at 18.6. But I bet many of you can see that this weight would be somewhat worryingly thin for most men of that height. To give you a little bit of historical context, BMI was invented by a Belgian academic named Quetelet, who focused on statistics and astronomy back in 1842. And he specifically said that it shouldn't be used to measure individuals, but was instead just to get an idea of the population as a whole based on the quote unquote average man. Shortly after this, it started to be more widely used, and in the 1970s, BMI category cutoffs were created based on percentiles, like they do for children, if that's something you're familiar with. So anyone in the 85th percentile of the BMI and up was considered overweight. This wasn't based on any health risks associated with these categories, just how you compared to other people in terms of weight and height. In fact, before 1995, the overweight BMI cutoff, according to the National Institutes of Health, was 27.8 for men and 27.3 for women. But 3 years later, in 1998, the US National Institutes of Health and the Centers for Disease Control and Prevention brought the US definitions in line with that of the World Health Organization, which lowered the normal BMI overweight BMI cutoff from 27.8 to 25, which resulted in 30 million people becoming quote unquote overweight literally overnight. One of the strange things about this overweight category is that the average Westerner has a BMI between 24 and 27. So around half the population is considered overweight and has been for decades. You can see based on this information that BMI categories are largely arbitrary. Finally, the last key point I wanted to bring up today is BMI thresholds, which created the obesity paradox. So what does that mean? So research has shown that paradoxically, people who fit in the overweight BMI category live the longest, and that people who fit in the obese BMI category are at no higher risk of death than those who fit in the normal weight category when controlled for other variables. So in other words, a healthy normal weight person has the same mortality risk as a healthy obese person. And so why is this considered a paradox? It's a paradox because of the expectation that weight is synonymous with health, in that thin equals healthy. Our society wouldn't expect somebody in a larger body to be healthy. And this expectation has been fueled in part by medical weight stigma. In fact, in 2013, the American Medical Association officially defined obesity as a disease as measured by BMI. This ruling actually went against the recommendation of their own committee, who identified that BMI was too flawed a measure and that there were no specific symptoms to obesity alone. The decision did benefit pharmaceutical companies who were previously struggling to get insurance to cover their newly released weight loss drugs. And finally, one of the many issues with BMI that I want to highlight tonight is that it was built only around measurements for white people. And while it works poorly in this population, it works even more poorly in populations of color and contributes to already established disparities and weight stigma in medical care for people of color. And now I will hand things over to Shira, who will discuss the weight-inclusive approach.
Hi, everybody. Okay, so we are going to get started in speaking a little more specifically now about what healthcare can look like when a weight-inclusive approach is used. And as you can see from all the things listed on this slide, this approach really focuses on health and well-being. And so we think about things like reduced LDL levels, and we think of these things as separate from weight. So we're going to be talking about a lot of the details around what goes into that, but we really want to focus on specifically health instead of weight markers. And so next, we're going to transition to looking at a little more detail around that. So as you can see, these are some of the benefits of a weight-inclusive approach. So when this type of approach to healthcare has been studied, the benefits include physiological benefits, so things like improvements in markers, in addition to the LDL I talked about, also things like blood pressure, blood sugar, as well as lifestyle behaviors like increased physical activity, reduced disordered eating, and psychological benefits, improvements in depression and mood and self-esteem and body image. One of the main foundations of a weight-inclusive approach comes from the Health at Every Size movement. This is a social justice movement with the 3 listed principles you can see here of respect, critical awareness, and compassionate self-care. Here's a bit more of a detailed look at the 3 principles. And as you can see, they're really relevant to healthcare because HAES focuses on behaviors that are specifically within an individual's control. And when you apply that to healthcare, it actually changes the approach that many healthcare providers have traditionally taken to issues related to weight. So these principles you can see here come directly from the HAES community website. They're an excerpt from the Body Respect book. This is by Bacon and Aframore. And if you're interested in learning more about this topic, I highly recommend the book. You can see that if you look at the 3rd principle, compassionate self-care, this starts to get into how nutrition and physical activity are approached from a Health at Every Size perspective, that these principles really keep the focus on honoring the individual and their body signals. Often HAES providers, Health at Every Size providers, are misconstrued as being anti-weight loss. And, as you can see here, there's really just no mention of weight at all. You can see that the section that focuses on self-care focuses on how to eat and move and not what happens to your body as a result of those choices. Because when you ascribe to the HAES philosophy, body size isn't an outcome that's relevant to care. We're going to spend some more time talking about weight loss goals within a weight-inclusive approach in a few minutes, but I just want to give you this foundation before we spend more time there. So before we get to that, I want to talk a little bit about what it's like to work with a registered dietitian in general. You're hearing from 3 of us tonight, so I want to explain what it looks like if you've never met with one. So if you meet with a dietitian, you can expect us to ask you about your physical health, your energy, your hunger, and of course, what you eat. People often come in thinking that we'll be the food police and we're going to tell you all the things not to eat. But I want to assure you that here at New York Gastroenterology Associates, this is not how our nutrition team operates. When we ask you about your current eating habits, we're not judging your choices. We're just trying to understand your day-to-day life and your day-to-day eating. Our goal is always to help you meet your own personal goals, whether that's simply to eat more healthfully, to improve or manage a disease, develop a better relationship with food. Our dietitians can work with you on dietary management of high blood pressure, cholesterol, kidney disease, diabetes, as well as dietitians work on other goals, improving quality of diet to prevent chronic disease before it starts, recover from disordered eating. So dietitians do a really wide variety of things. And here at New York Gastro, the dietitians are also specifically trained in the management of gastrointestinal disorders, so we can provide you with evidence and clinical experience-based recommendations for those. In terms of the logistics, our nutrition team meets with patients both in person and through video appointments right now. Next, I want to highlight what makes working with a weight-inclusive dietitian a little different. And since, we're dietitians, I'm going to start there, but then I'm going to expand and talk a little more about other healthcare providers as well and what that looks like. So Health at Every Size aligned or weight-inclusive providers work with patients to set goals that are focused on compassionate self-care. So we really work with things that are within your control as an individual. Of course, we do work with people who would like to change their body, but we think that when we're setting goals of treatment, we really want to focus on behavior change instead of a body change goal. And I think this is important for a few reasons. The first is it actually doesn't change what we do together. It changes how you measure your success only. So I'm going to give you an example. I often work with people who find they eat beyond their physical comfort level. They leave the dinner table and you feel full, uncomfortable. And people do that for a variety of reasons, right? And I'm sure you know some of these. Sometimes people may eat too little during the day and they go into dinner incredibly hungry. And so of course, then it's hard to manage the amount that you're eating at dinner. Maybe you're eating a meal that's not well balanced. And so then later on in the day, you don't stay satisfied between meals. And maybe you feel like you also have to finish everything on your plate. A lot of people were trained that way as children, and so they find it very hard to not finish everything, even if they've, their body has said you're full, they feel like they need to finish that plate. So let's say you're working hard to change this behavior, and now you're typically eating balanced meals regularly throughout the day in a pattern that works for you, and you're leaving the dinner table feeling satisfied, but not overfull, not uncomfortable. I think that everyone who accomplishes a goal like that should feel successful. And in a weight-inclusive model of care, they do. They set a goal, they achieve the goal, success. Unfortunately, in a weight-centric model of care, if you work hard to do this and you accomplish it and that results in weight loss, then you're successful. But if you work hard to do this, you accomplish it, and you don't lose weight as a result, you feel like a failure. And that just doesn't seem fair or reasonable to me. Now, sometimes people wonder about how they fit into this model because they do want to lose weight. And so I want to directly address how we talk about weight loss in a weight-inclusive model of care. Weight-inclusive providers are not anti-weight loss. We just don't focus on weight as the measure of success because we want to focus on behaviors you can control. And while often weight loss goes along with behavior change, being 120 pounds exactly is not something you can do behavior-wise. If you set goals around healthy eating, you may indeed lose weight, and many people do, but all bodies are different and all histories are different, and we can't promise that. So if you do lose weight, the amount also is not always something you can micromanage. If you make healthful dietary changes, you will improve your health, even if you don't see the number you want to see on the scale. And so we really like to focus on that health improvement instead of the number. So let's take an even more detailed example. So you want to lose 20 pounds and at least 1 to 2 pounds a week. So this is the goal you come in to meet with a dietitian with. Now, you don't eat a lot of vegetables currently, and so you start working with the dietitian, you together decide to add them into dinners, you come up with ideas of how to do that. You do it. You're eating sizable portions of vegetables 5 nights a week. Your energy is good. You don't feel bloated and refluxy every night at bedtime. You are pooping like a champ. But you only lose 2 pounds after doing this for a month. Weight-inclusive approach, success. What change should we work on next to improve your diet and health? You continue to make healthy changes. It's a process. The weight-centric approach, failure. You didn't lose enough weight. You feel frustrated. You stop eating vegetables. You might as well go back to eating burgers and takeout since it's just not worth it to make the effort to eat well. It doesn't work. So, this is really the reason why we love this model of care. We just think it's a much more workable one to keep going and be successful over time. Another reason that a weight-centric approach can be problematic for people around dietary change is that, if you make those specific changes, let's say you go to the gym and you exercise 40 minutes a day, 5 days a week, you end up with this reasonable plan and you like it and you don't achieve the weight loss you wanted, that can actually stop you from engaging in those healthful behaviors. Sometimes people, in order to meet their weight loss goals, have to engage in unhealthful behaviors like disordered eating or things that aren't sustainable, like avoiding all social occasions so that you don't eat any fun foods. And those things are usually not sustainable in the long run. And if they were, they wouldn't be a good idea for you. And so you would also likely regain any weight you lost using those approaches. So while weight loss, weight-inclusive dietitians are not anti-weight loss, we are against people engaging in unhealthy behavior, and we don't want to set you up to do that. Now I want to talk a little bit about what it would look like to work with other types of weight-inclusive healthcare providers beyond dietitians. Now, if you are meeting with a weight-inclusive provider, a doctor, a nurse practitioner, a PA, the physical environment would be comfortable for people of all bodies. There would always be a variety of blood pressure cuffs and gowns, and that would fit people of different sizes. Chairs wouldn't all have arms so that bodies of all sizes could fit comfortably in them. And recommendations given by your provider would be the same, regardless of the size of your body. People wouldn't automatically be weighed at the beginning of the visit. Instead, you would actually only be weighed if that weight was going to be used to drive your medical care. BMI wouldn't be discussed. And as weight stigma gets more and more attention and more medical societies put out recommendations that ask doctors and other providers to be careful about weight stigma, we have seen a shift in some healthcare providers' discussion of these topics. Now, when patients tell us what their provider said about their recent weight gain, they say things like, they were as kind as possible about it, or they were really very nice about it. And while that certainly is good that they were kind about it, the problem with the shift is that weight loss is still often the recommendation that people are given. And as a general public health message, provided without detailed knowledge of what you eat, how you exercise, your history, whether that includes disordered eating, the message to lose weight is still often not helpful and can be harmful. And it's not helpful for a few reasons. The one is that we've talked about a lot, and so you're familiar with that weight loss itself is not something you can do. So you don't really walk away with any specific recommendation that you can go and implement. The second problem is because we know that most people who lose weight will regain it within 2 years, unless things change and we have an evidence-based treatment that really does help you lose weight and keep it off in the long term, it's a recommendation that a person is just unlikely to be successful in implementing over time. And finally, this recommendation can do harm because it can trigger disordered eating, crash diets, or lead the person to avoid future needed medical treatment because they don't like to have those conversations and they get less medical care in general, which of course isn't good for anybody's health to avoid medical care. Also, in an ideal visit with a weight-inclusive provider, you would not leave a doctor's office feeling like you caused your own medical condition because your body was too large. And we hear from patients all the time, this is how they leave feeling. It's my weight, it's my fault, I'm too heavy. And we don't feel like that's the way people should leave. So that would be, ideally what you would experience and what you would not experience at these visits. I want to take a couple minutes to share a couple of case studies for a couple of common conditions that we discussed with patients and highlight the differences in treatment between a weight-centric and a weight-inclusive approach. So first, we'll talk about non-alcoholic fatty liver disease. In a common weight-centric approach to this condition, we often see healthcare providers telling patients to lose weight to improve their liver function. In a weight-inclusive approach, the provider would say something like, there are a lot of data showing that diet change is the primary treatment to manage your fatty liver disease. Would you like to meet with a dietitian to talk about therapeutic dietary treatments for fatty liver disease? All people would receive the same advice, regardless of the size of their body. Now, while I've noted before, often weight loss does accompany healthful dietary change. Even if it doesn't, we know that there's a set of dietary changes that can improve your liver function, regardless of whether your weight changes or it doesn't. So one example of that is to change your dietary pattern. It's not great for your liver to eat very little during the day and get most of your energy at night. So changing your pattern so that it's more evenly distributed throughout the day, or you eat more earlier in the day compared to at night, can be helpful, even if you're eating the same amount in total throughout the day. A Mediterranean style dietary pattern can also improve your liver function. So dietary changes might focus on eating more fiber-rich carbohydrates like legumes and beans, fruits, whole grains, eating less bread, white rice, potatoes, chips, and things high in sugar and sweeteners. You can also focus on including things high in unsaturated fats like fish, avocado, nuts, olive oil, and eating less of the saturated fats from animal products like red meat and higher fat dairy foods. So as you can see, there are a really wide variety of things that we can work on that can improve fatty liver disease. And we'd love the focus to shift to that, and that's what a weight-inclusive approach would look like. And then secondly, I want to talk a little bit about gastroesophageal reflux disease, chronic acid reflux, and weight loss is often also recommended to manage GERD. And so in a weight-centric approach, the doctor diagnoses you with GERD and tells you to lose weight. And while weight loss does help reduce GERD for some people, it's not always the cause, and it's also not the only way to manage it. A weight-inclusive approach would be where your healthcare provider instead says something like, there are lots of triggers for GERD, and we can talk about managing some of the triggers today. Having more fat in your abdominal area can also trigger GERD. Would you like to meet with a dietitian to discuss behavioral changes that might impact your weight and focus on other dietary patterns that can also help manage your GERD? When you would meet with a dietitian, we'd then spend time focusing on each of the areas that can help you manage your GERD and tailor our recommendations to you as a person, taking into account what's important to you, what your life looks like day to day, and what things seem to be problematic for your specific gastrointestinal tract. Now, we have spent some time discussing what we think is the kind of ideal way to provide weight-inclusive care, but as you all know, unfortunately, this is not what most people get right now, but we hope that will be changing in the future. And so we want to end our presentation today by providing some ideas of ways you can advocate for yourself if you're experiencing weight stigma in a medical setting. It can be difficult to know how to handle medical weight stigma in the moment. So the cards you see here were created by Ginny Jones. She's a parent coach who helps parents handle their kids' food and body issues. And these can be a helpful tool to share with your healthcare provider at your appointment. They're a polite way to initiate a conversation about whether a provider really needs your weight. And if they do really need your weight, then you as a patient can make an informed choice about that. It's a little bit of a different mindset in that being weighed at your appointment can be a conversation rather than an assumption. Now, if you feel comfortable engaging further in a conversation about these topics, you might try some of the following strategies. So let's say your doctor or other healthcare provider recommends weight loss as, part of your treatment or as the only treatment for whatever you're struggling with. So you could say something like, let's pretend for a minute that weight loss is not an option for me. What other treatment options would you recommend? Or if I were in a smaller body, would you have some different ideas for me? Now, of course, not everyone wants to have this conversation or is able to have this conversation. However, from what we've seen, especially over the last couple of years with respect to other isms, things like racism, is that in order to create change, we have to have uncomfortable conversations. And so if you're willing and able, this is something I really encourage you to do. Finally, always keeping in mind that you have the option to seek a second opinion and find another healthcare provider if your current one doesn't seem open to having this conversation with you, and it's something that would be really important and helpful for your medical care. Again, we understand that that's not always easy. Sometimes access is difficult, logistics, insurance reasons get in the way, but to the extent that you're able, you don't have to continue to receive care from any one specific provider. So on this slide, we've provided some resources to help you learn more about this topic if you want to. Of course, the handouts on these websites, you'll see both the Hayes health sheets and the Creating Peace with Food are not substitutes for medical advice, and we recommend anyone with a nutrition-related health concern see a registered dietitian. But sometimes it's helpful to get some idea of the options out there, and so we wanted to give you a starting point. You can see there are books, there are websites, podcasts, an article, and a blog. So a variety of ways to get started getting more of this information. And now we're gonna thank you for listening. We really appreciate your time. And now we have a little bit of time to answer any questions that you might have.
Yeah, thank you both. That was so great. I just want to emphasize that I think that this is really the future of healthcare. And so for anyone listening tonight that feels like this is like a new concept, new way of thinking about weight in healthcare, this is really how we're going to see healthcare transform in the future. And so all of these really tangible, kind of tips and, ways to advocate for your health are super important. And we have a few really interesting questions here. Some of them I think you guys kind of covered, but I feel like it would be really helpful to recap some of these points because they're so important. So one question is, if someone's receiving stigmatizing language or actions from their healthcare provider, how can you talk to that professional without getting too confrontational or ending up in a conflict?
I think that's a great question. I think I will say before I kind of give a more useful answer to this question that it is always hard to say how people will react. So it may be that no matter how friendly you are, no matter how kindly you say something, people will still get offended. There's just no way to guarantee that they won't take offense, especially sometimes if somebody realizes they've done something yucky because of what you say, they may get defensive about that. And so I think there's no guaranteed way to do that. I think the best way to get started, though, is to just speak about your feelings and be honest and say, doctor, I really appreciate your time and your advice, but I wanted to let you know that when you said X, I felt really hurt, and or, whatever actually came up for you, I would be honest about that feeling. Or I felt, really triggered when you said that. It made me want to do X, Y, Z. And I think that's important feedback for them to get. And so that's what I would advise, is really kind of just talk about specifically what they said and then how it made you feel. And then, if you want to say in the future, I'd really rather we not talk about my weight, or we focus on other options, or whatever you would like to see them do differently, if you feel ready to kind of give them a next step.
Yeah, I would just echo that with kind of the idea that you as a patient, you have the right to have, meaningful and open conversations with your healthcare providers. And to the extent that you're able to do so, I really, encourage you to initiate those conversations when you feel comfortable.
So, one thing I know we hear a lot, because we see our patients and after they've maybe met with their physician, what do you think a patient should do if the doctor says, you should lose weight? That's kind of the main recommendation when they leave a visit. What is an appropriate response?
I think it depends on how brave you're feeling that day. I think the kind of gentlest place to start is to say, oh, I hear that would be a good option, but what other options do you have? What other things might help? I think is like the gentlest way to get started with expanding that. And hopefully they'll recognize that then they should be providing you different options. I think if they don't, then the kind of pokier and way to say it is, if I were a smaller person, would you have any other ideas for me? To really make it clear that you wonder, is it your size that is changing the recommendation they're giving?
What do you guys think about, being sort of an advocate if you are a caregiver for someone else, or you're involved in someone else's healthcare? So one question is and I'm sure there's other parents here tonight listening too, but one question is, going to a visit for your child and the doctor making a comment about your child's weight. How can you prevent that from happening in the future? At another visit, you still like that physician, you think they're providing really good care, but you maybe don't want to have that as part of your person's healthcare experience, whether it's a child or a parent, a spouse, whatever it is.
Yeah, I think it can be even more difficult sometimes when we're not talking about your own personal care, but that of a loved one. With respect to if it's your child, there are actually similar Don't Weigh Me cards specific to a child made by the same person. So, if you're a caregiver of a minor, you might, ask their healthcare provider, please don't have any conversations regarding weight or body size without me present in the space, so that you might better be able to sort of modify the conversation as needed, or be able to be there for them.
I think it would also be very fair to say, and it depends on the age of your child, if you have a way to get the doctor alone with, the kid going to the waiting room a few minutes at the end of the conversation when this first comes up, a way that you could speak to the doctor without the child listening. You could say, listen, I have a lot of experience with people with eating disorders. I really don't want my kid to develop one. And I know that talking about weight can be one of the risk factors. So I am happy to engage in conversations about healthy lifestyle choices and what we can do as a family to stay healthy, but can you please avoid specifically mentioning weight or body size going forward? I'd really appreciate it. I think they would, understand that worry and that choice.
We have another question that's a little unrelated, but it might be just a good way to round out this whole talk since we're all dietitians here. One of our favorite questions, what's the difference between a dietitian and a nutritionist?
What a great question. So essentially, dietitian is the licensed term. So we have a whole host of different qualifications and certifications necessary to practice. So that as of 2024, that includes a master's degree. It includes a dietetic internship, which is typically a year-long kind of clinical practice fellowship type of experience. And then we have a national board exam that we have to pass. And based upon, the state or states that you're practicing in, certifications that are state-based. And then we have continuing education credits that we're responsible for. So that's kind of the difference there. Anything you want to add, Shira, that I left out?
Sure. I'll just say that it can be confusing because you can call yourself one of two things now. You can call yourself a registered dietitian or a registered dietitian nutritionist. I would say nutritionist is a more commonly understood phrase, and so I use that one quite a lot. So I would say that all dietitians are nutritionists, but not all nutritionists are dietitians. And so the way you can tell the difference is if you look for the credential, somebody has to have an RD or an RDN after their name to have that list of things that Faith mentioned. And if they do not have those letters after their name, then they may be somebody who is trained in like a weekend type program or just have a lot less training. And so there are people who call themselves nutritionists with a much more minimal level of training.
Great. So, just a reminder, this webinar will be recorded so you can share it with others or catch the replay if you were doing some multitasking, and, reach out to any of us if you want to set up a telehealth appointment, if you're interested in nutrition services or you want to talk more about these topics and how they pertain to you. We're all really interested in talking further, and thank you all for attending. This was great.
Thanks everybody for coming.
Well,